Hey, welcome everybody to a review of TFOS DEWS II, this global dry eye consensus. And I'm going to make sure I can move my slides. So I'm joined tonight by a superstar faculty. By design, I got to pick some of these people. So surround yourself with people with the knowledge that these have, and it becomes easier for me. Chris, welcome. Chris Starr, who's been co-hosting a podcast with me for several episodes, who was also on the Public Awareness Committee for TFOS DEWS II. Chris, give us a brief background other than your Good Morning America gig. You do some other stuff too, right?
I do a couple other things. Yeah. Well, first and foremost, I want to say I don't really consider myself your co-moderator or co-chair. I'm actually your sidekick. So think of me as like your Ed McMahon equivalent. I'm Chris Starr. I'm a star in name only. But the other people on this call are definite stars. And Priya and Kelly and Zaina, we're honored and delighted to have you here as true experts in this area. And I will say that even though this conversation is based on the TFOS DEWS II report, which most of us were involved with in some capacity and certainly have read it and live by it, as the quote unquote Bible of dry eye. We're going to also try to make this is going to be loose. We're going to talk where things are going to come up. We'll probably run long on parts, go short on others. And we're going to try to make it as sort of practical as possible. The DEWS II report, TFOS DEWS II, was well over 400 pages. And while we've all read it, none of us can retain all of that information encyclopedically. So, there's a lot of science and there's a lot of practicality, and hopefully we can cover the best parts of both.
Great. And Zaina, it's Almatasib, correct?
That's really good.
Okay, good. So I actually had a chance to meet Zaina on a paper that we worked on together. And I was so impressed with your insights. We worked on device use in dry eye, and that's how I came to know who you are. And I know you offered so much value in that paper. And tell us a little bit about what you're doing at Baylor.
Thank you so much. And really excited to be a part of this. So I'm associate professor at Baylor. I'm a cornea specialist. I also associate residency program director. So in addition to obviously being a tertiary center for these types of complicated patients, especially the advanced dry eye disease, I'm really involved in residency training and education. So really believe strongly in the education component of what we're doing today.
Great, and thank you. And the fabulous Dr. Priya Gupta agreed to join us today, and really honored to have you here, Priya. I've been a fan of your work for many years. Tell everyone a little bit about what you're doing at Duke.
Yeah, well, I'm a cornea, cataract, and refractive surgeon at Duke, and I've been there for a decade. It's hard to believe. And, my journey with dry eye and ocular surface disease is that I fell into it and by accident, and who knew that it would be this ever growing and important area. And, I personally am passionate about it. A lot of my research interest is in it, and it's been awesome, especially working with Chris, on a lot of new topics, new algorithms, or ASCRS Corneal Clinical Committee paper, et cetera, among other studies that really, what I love about ophthalmology is the ability for groups of people to come together and work together and have friendships. And, that to me, some of the fun that I have with ocular surface disease is because of all of my colleagues, all of you guys here today. And so there's still so much that we have to learn, and so much that we are learning as we go. And I'm just so thrilled that the audience today is, hundreds of people. Really, a lot of interest in this topic. And so thanks for having me.
Yeah, thank you. And Kelly Nichols, who's, I have a daughter kind of like you, Kelly, who's collecting letters after her name. So far, it's simply MSMD, but I know she's wants more after that. So thanks for joining us, Kelly. And Kelly's someone who, Kelly, I can recall the first time we communicated, I think it was at Academy in San Francisco around 2011. And I used this term, which I don't I'm not a fan of anymore, but I wanted to pick your brain because I was starting into the dry eye world about 2011, around the time of my LASIK, and you were kind enough to take a few minutes to talk to me. So I've always appreciated that. But tell us what's happening in your fabulous world in Alabama.
All right. Well, thank you so much for having me tonight on the show with all of you. It's a pleasure to get together with colleagues I've known many of you for some period of time, but it's also great just to be working with you. And then all of our colleagues out there, I just want to say welcome, and we look forward to giving you a little bit of insight about dry eye that we're also passionate about. I am professor and dean at the UAB School of Optometry, and also really fundamentally have been a dry eye researcher, both from the clinical perspective and the basic science perspective, for longer than I'd like to admit. And back in the beginning of dry eye for me, it really was trying to find a disease to study for my career that was going to be something that optometrists could really relate to. So the fact that we have so many registrants here tonight really is a testament that we are doing a good job at really letting people know that dry eye is something that we can all manage together. And I guess my motto is that while you learn a lot about things that you can do, the way to start is just to keep it simple. And we're going to talk a bit about how this will translate into clinical practice as we go through this evening. So welcome, and thank you to everyone in the panel.
And translation and simplicity, that's what I am all about as a private practitioner. It's got to be, I like to practice evidence-based medicine, but it's also got to be very efficient. And before we move on to the next slide here, the humble Chris Starr, who put together the ASCRS algorithm for preoperative evaluation of the ocular surface, based somewhat perhaps on DEWS II. That was a great piece of work that you did. And Kelly Nichols actually was behind the MGD report, which I think was that around 2011, Kelly?
Yes, it was. That's when it was published.
I know all of you have been involved in a lot of impressive research. So thank you again for willing to be part of this. These are some companies that we do some work for, and we'll move on. So we have just 3 learning objectives tonight. We'll talk about the current state of dry eye and this increasing prevalence. Absolutely, I think we can all agree we're seeing more of it. The pandemic has added to that. And the need for doctors to screen for dry eye. And that I think is really so key. You have to be proactive about screening, but it doesn't have to be complicated to do so. We're going to talk about TFOS DEWS II consensus and differentiate the findings from the subcommittees. We won't get to every subcommittee, but we'll try to get to most of them. And primarily what we'll focus on today is going to be definition and classification, diagnosis and management, because that's what doctors want to know. How do I diagnose it, and how do I treat it, and how do I do that efficiently based on the science? And we'll talk about the key elements of DEWS II consensus and propose ways, like I said, to apply this. This is designed to be translational. So here's some information on the CE and the CME credit. We want to thank our support from our sponsors, Alcon, Bausch & Lomb, Johnson & Johnson, Surgical Vision, and Tarsus Pharmaceuticals, who has an exciting new drug coming out for Demodex blepharitis. So thanks to our sponsors today. For accreditation, basically what you need to know, we're going to get you all this information. It's going to be emailed to you. You will be sent an email with instructions on how to get your credit, and we'll give you information on how to, if you have any troubles with that, we're happy to help. For comments and questions, there's a QR code, or you can go to the website. You can just, of course, as you know, as we all do in restaurants these days, we put our phone on a QR code and we know what our menu is. And that's what you can do to get to the polling questions, which there will be 3 of. So, Kelly, let me pick on you here. And why don't you give us some insight into this, TFOS DEWS II is the 10-year update, right, of 2007. And talk a little bit about, and Chris, maybe you can chime in on this as well.
Sure. So the TFOS DEWS II, of course, was to take a look at DEWS I and make an assessment of what had happened since that was published in 2007. And a lot has happened in the 10 years that span between 2007 and 2017. So you first start out with a steering committee taking a look at, well, what are the main areas that have really grown in the last bit of time that we really didn't emphasize maybe in the first report? And then how do we put together a group of people who can be in each of these subcommittees? So as you can see, there are over 150 ODs, MDs, PhDs across the spectrum of clinicians, bench scientists who got together. They were selected to be on the subcommittees based on their expertise. And we'll go over the subcommittees in a little bit. And then they reviewed not only what had happened in the 10 years, but if there were important things that had to be carried forward, they would review those and put in context the 10 years worth of new information that had come forward and that created a gigantic, series of manuscripts, which I don't know. I guess I've read all of it because I had to do some editorial comment on all of it, but it's hard to find somebody who's really read all of it because the pathophysiology report is over 200 pages. And the whole thing Chris mentioned earlier is well over 400 pages. And I always say to my students, if you really want to have a good night's sleep, just start reading that. And then maybe you can put, especially the pathophysiology, wonderful stuff there, but lots and lots of deep, deep information. So the subcommittees all got together and they had a process of reviewing and making assignments to the people in the subcommittee. Then they drafted an outline and then filled in the gaps with the written words, and then had draft reports that were circulated amongst the whole group for review and comment. There was even a meeting where everyone did presentations on where they were to date, and there was comments from the audience about things that needed to be added to the sections or enhanced in the different areas. It really did take 3 years to get all of this together from start to finish in terms of just really getting all the details and everything written very clearly and harmonization across all the different subcommittees. So then this provided really a good framework for what had been done, what was known, and what we could do going forward. I like to think of these reports as the blueprint for the future so that any clinician or scientist could pick it up and find several questions that they could answer and take forward into the next 10 years for the, hopefully, DEWS II sometime down the road.
Right. And I think, when I talk to doctors, and you may do the same when they aren't sure what to do, this is where I direct them because it has information on how to screen, diagnose, and treat, which leads us to Dr. Priya Gupta, who Chris and I had the pleasure of talking to on the podcast just recently. And I love this. We talked about I run a Facebook group called OS Docs, and I'll see some of these presentations and doctors are like, oh my gosh, I don't know what to do. So tell us, Priya, a little bit about the chaos of dry eye.
Yeah, I used the word chaos and it just came out as I was talking to you because it is chaotic. We have all this interest in creating algorithms and guidance, right? And if you think about, well, why are we doing that? It's because it's confusing. There's an inherent disconnect, just if we look at the disease itself, between the signs and the symptoms of dry eye disease. So to begin with, right off the bat, we have our patients that might have the disease, but maybe we can't see it in our traditional methods. And then we have patients that come in where we look in and we say, oh, you should feel terrible. And they have no sensation. And they say, I don't know what you're talking about, doc. I'm doing great. And so, at the get-go, as a disease process, sometimes dry eye gets mislabeled as, is it really a disease? Is it really important? Is it meaningful? Does it really cause all the problems that people say it does? And I think, here in 2021, if you don't believe that dry eye causes problems, big and small, then I think that you've kind of been living under a rock because certainly from a surgical perspective, that's where a lot of us are coming from. But look at all the literature on quality of life and, things that actually matter to patients. Can they do their job? Can they, if they're there, are they present at their job? Just so much in the literature that we've learned. And, one of the things I have to commend the TFOS DEWS II report is just the volume of literature that was reviewed. I think these two initiatives, DEWS I and II, were about 10 years apart. And Chris, how many more articles were there?
Well, the amazing thing about the TFOS between DEWS I and TFOS DEWS II was that for the centuries before TFOS DEWS I, there was literature in dry eye. And that literature between 2007 and 2017 doubled. So
yeah, I mean, that's
thousands of papers before that, it doubled, and
astronomical.
You credit TFOS DEWS I for really lighting the spark, as it were, that essentially established a new subspecialty of eye care, I think, and ocular surface disease is a subspecialty unto itself.
Absolutely. And even Chris, like thinking about something as simple as a definition.
Yeah.
And what we
easy.
Possibly not agree on a definition. Of course, I mean, this is so, I would still say today we have a working definition, but that clinicians might have a slightly different perspective here and there. And so really, there's very few conditions where we question the definition. So that, to me, that just at its most, building block level, entry level, this is a chaotic disease. And for clinicians, like what do? We like to treat things and be done and move on. And that's not what dry eye disease is. It's a chronic disease, and it gets better and it gets worse. And sometimes we don't know why. And so, all of that really is why the word chaos came out of my mouth the other day. And so, the other things on here, so diagnostic. So forget about the definition and confusion around the definition, but how do we diagnose it? The signs and the symptoms don't correlate. We don't have necessarily a linear pathway. And this is where I think these algorithms have really helped to guide the clinician. And I use the word guide because I don't think it's realistic to say, look at all of us, even just the handful of us here on this call, we all practice differently. We all have different environments. We have different volumes. We have different patient types. And so, it's difficult to say to somebody, if you're going to diagnose dry eye, you have to do it this way. And I think that creates a little anxiety in docs that sort of want to try to do this, but don't really know if they want to be able to commit to an exact algorithm and, all the questions that kind of spell out from there. And so, I think that's why we do things like this, because I think it's interesting to hear, okay, well, how are you adopting that algorithm? What's your take on, what if I don't have osmolarity? What if I don't have MMP9? What if I what if this is just what I have? Can I do this? And I think that's, to me, the specialness of where you can hear how each individual has decided what test is actually meaningful and, where it's helped them and, what things didn't work out for them. And so, certainly part of our goal here, Scott, tonight, I hope, is to reduce some of the chaos. And really, we could talk for 10 hours on this topic. We're not going to.
Absolutely.
Right.
Well,
but I would also just say that anybody who says ocular surface disease of dry eye is a mundane, simple, easy thing to deal with, you're simply not doing it right.
Yeah,
Plain
look at all the
subcommittees. I'll put in the vote that instead of calling it the dry workshop 3, I think it should be more the ocular surface disease workshop, because masqueraders are a big confounding problem with dry. There's a lot of times where we're not looking at dry, but it's an ocular surface disease, something a little different, right? So, Chris, you want to take us through the subcommittees briefly?
Sure. And I would say if it does become the OSD workshop, that instead of 400 pages, it'll be 4,000 pages.
That's correct.
But anyway, the subcommittees.
We're all going to need a 3-month vacation with a daily agenda of a reading plan, like summer reading when you were in grade school.
So the subcommittees were definition and classification, and all of these, like Kelly said, harmonization. Is it homogenization? Harmonization. And they were all harmonized and they're all integrated. And there was very little repeating, believe it or not, amongst all these subcommittees because they were harmonized by the steering committee, which Kelly was part of. There's definition and classification, sex, gender, and hormones, which I think might have been a new one for this report. Yes, epidemiology, it was, right? Yeah. Mm-hmm. Tear film, pain and sensation, pathophysiology, iatrogenic dry eye, which is important. Diagnostic methodology, management and therapy, and then interestingly, the clinical trial design, which is kind of fascinating. And as we all know, at least people who practice in the US realize that there hasn't been a whole lot of things FDA approved in the last decade. And a lot of that falls under the clinical trial errors that are made when setting up these things. And so if you read that subspecialty report, there's a lot of really fascinating advice for companies and investigators to do better with their clinical trial design. And actually, since it came out in 2017, actually there have been a few approvals, more than I think between 2007 and 2017. From Restasis to Xiidra, there was nothing, and then since 2017, and maybe we can give some credit to the clinical trial subcommittee for guiding design of trials, that at least I can think of off the top of my head, at least 3 things have been approved in the last few years. So success there. But anyway, I digress. Let's go to the polling.
And Zaina, I'm going to give you the honor of reading the first polling question, if we can get everybody to do that quickly as you can. And you're muted.
According to TFOS DEWS II, all dry eye disease eventually has an evaporative component. True or false?
And this is something that I learned during our podcast, Chris. I did not know the answer to this question. So I'll give everybody just a minute. And Jarmy, our support team, are we going to see results, or you're just going to share them with us? And they may not be able to respond, but somehow I hope we can find out the answer to the question. %70 true, 30% false. Okay, good to know. And Chris, what's the right answer?
The right answer is A.
True.
According to the TFOS DEWS II report, all dry eye eventually will become evaporative. And in fact, there was some debate behind the scenes about maybe using the term evaporative and hyperevaporative dry eye. And I think the consensus was that, well, let's keep aqueous deficient and evaporative dry eye as the 2 fundamental subtypes, but with this understanding that, all dry eye will ultimately become evaporative.
And then you can get into the Asian definition of dry eye, which is short breakup time dry eye. They have a whole different thing. And
right.
And the use of evaporimeters, which I believe Mark Wilcox from the tear film section was hoping that we could someday see in practice. So the correct answer is true. So Kelly Nichols, this was near and dear to you, and I'm sure you worked very hard on this. I know Chris and I spoke to you a while ago. So take us through the changes from how important each word was here, right? When you took this in, this was not an easy thing. You're trying to make it concise. What was the discussion here, and how did you end up with the new definition?
Well, we had a very international subcommittee because we wanted it to be an international definition. And although, there are kind of different parameters of dry, like you just mentioned, and different definitions a bit that are sort of morphing as time has gone on, we wanted to have some fundamental words in there that could be accepted across all languages. So we did a lot of, well, what does this word mean? Let's look it up in the dictionary. Let's look it up in the medical dictionary. How does that translate into Korean? How does that translate into Chinese? Is it 1 word or 2 words, and that sort of thing in terms of every word that we used? The loss of homeostasis was a big addition. We felt like we wanted to try and make the definition simple, like you mentioned, Scott. And so if we could try to understand what was going on with the tear film, and if it was losing its homeostasis and the ocular surface was losing its homeostasis, the goal would be to return to homeostasis with treatments. And so we wanted to see if the word homeostasis tracked across different languages. And for the most part, it did. It isn't 1 word in all languages, but the word choices that make up how you would define it in different languages were enough such that the sort of idea behind using loss of homeostasis as a hallmark sort of element of the disease definition was important. So that was actually, I think, a big step forward for us. Then we wanted to decide whether or not we could leave it there. Could we just have it be a loss of tear film homeostasis that maybe is accompanied by symptoms? What about all the other things though? And so there was a lot of debate about what other words we added in the latter part of the definition. So should we have hyperosmolarity? Should we have ocular surface inflammation or neurosensory abnormalities? And we ended up there were words like cause that were being used and resultant of that were being used, and we couldn't really decide. So through a harmonization special meeting, we got together and decided that we could include those latter big words to sort of outline the etiologic pathology and roles that they would have without saying what causes what and what leads to what, but they were there because without them being there, we were sort of ignoring all the work that had been done over the past 10 years. And we wanted to somehow reflect that those things were important. We didn't want to have to go back in 10 years and make a new definition though. And so we wanted it to be something that could stand the test of time. So adding neurosensory abnormalities was a bit of a leap of faith because that's the one area that we don't know as much about right yet. And we probably will learn more. I suspect that as we go forward to any new definition down the road, that we'll be deciding whether or not that should be included and should we add more. So we kept it pretty succinct, I think. We translated it into different languages to make sure that it had the same meaning. And we tried to aim for something that could be utilized in clinical practice as well as for regulatory agencies who look at the definition to decide whether or not the outcomes that are being selected for clinical trials are consistent with the definition. So it was a bit of a labor of love, and there was a lot of, you'd think, are we arguing over a period, a comma, a word? Let's look it up in the dictionary. And yet at the end, I think it was something that we're all quite proud of to be part of and to come to the definition as we have it right now.
And so symptoms are now required to be considered that you have dry eye.
Yeah, that's really interesting because we've done some work lately where we've been really applying the TFOS algorithm. I would say, I mean, that you can have, so here's the big question. So asymptomatic MGD, is that dry eye? Because it's asymptomatic, so it doesn't make it into sort of the algorithm for screening because it's asymptomatic. So I think we're going to continue to bump up against questions like that because certainly that's evaporative and try to decide how these things all fit together. But obviously, if someone has symptoms, they talk about them and then you do some tests to try and confirm that person does have dry eye, and that maybe is the easiest approach. And so if we start with the easiest stuff, then we can see how the other things fit in.
And we're looking right now at the 2007 classification, which, right or wrong, my interpretation was this was an either or proposition. Was that what that was? Were you involved in the original dry workshop, Kelly?
Yeah, I was.
Is that what that was meant to be?
Well, actually, the very, very first one, no, I wasn't. But this, no, it wasn't. And if you read, of course, this is the hazard of having a figure that doesn't live with its legend and doesn't live with the words in the document. Because if you do read the words in the document, it does give some language about how it can be this or that, it can be that, or it can be a combination of the two. But what happened was this diagram really got separated from the words. And so it really did start living in a space where it was this or that and nary in between. However, I'm sure all of us that are here tonight have given lectures where we would say, hey, audience, what percentage of your patients do you think are evaporative? You know, what percentage of your dry patients do you think are aqueous deficient? What percentage of them do you think are somewhere in between? And like everybody raises their hand. So I think that it did get a bad rap for being this diagram that lived forward, but we tried to address that in the next, in 2017 with the new classification scheme. And actually that shows up at the bottom here where you can see that it is aqueous deficient or evaporative, and they can go back and forth with that sort of two-way arrow that's sort of in yellow and blue, saying that you can start on one side and move towards the other in both scenarios. And so what becomes important if you work your way through the diagram and you end up with dry eye disease at the bottom is determining how much of which one you have and addressing that particular component perhaps first, if it's the overlying reason. So if they have more evaporative dry eye, you might address the meibomian glands before you would address something else, for example. But importantly, go ahead, Scott.
I was just going to say, Priya and Zaina, when you talk about the chaos, I think fairly simply, this brings organization to the chaos. It's something that I think there'd be value in putting in your practice. Again, it's not the end all be all, but it's a great starting point. That's for sure. Right. And would you agree?
Yeah, no. And I think just to add in terms of the chaos, I think it's also, the benefit of, we talk about all these new treatments that we now have for dry eyes that we didn't, 10 years ago. but really it's also all the new diagnostic materials, right? I mean, mybography and all of these things that kind of even bring up the fact of how do we find out that they have these issues while they're asymptomatic, right? It wasn't even a discussion before because our diagnostic criteria, our diagnostic equipment was very limited, who sat there and does a Schirmer test every single time, right? So now we have all these objective ways to treat it. And that's why I agree with you, simplifying it to think about it in a way where, is it symptomatic or is it not? And then thinking about, do they have signs? And going through that algorithm really tries to help and simplify it.
Great points. And Zaina, since you've got the floor, Chris, I got to tell you, Dr. Sullivan was a guest for us, I believe, in 2 or 3 of our podcast episodes. And I mean, I've known Dr. Sullivan for a while, but his depth of knowledge and experience was profound to me, going back to his early research in the 1980s. I think it sounds like he discovered dry eye disease in rats, I think is what he worked on. That was his first. Who knew? So, Zaina, the sex, gender, and hormones, it's very topical. Take us through, your thoughts on how in your practice this comes into play.
Well, I think in general, people, when they approach dry eye, I would like to, kind of remind people they used to think it was just the female disease, right? Female old patient was the only patient that had dry eyes. So it's just very interesting. So we obviously know that dry eye disease is more frequent in women than in men, and that it's a significant risk factor, but it also is more significant with increasing age. And what's interesting is that you have to think about the other way around, is that, not all dry eye patients are female. You have the males, and now we're looking at younger and younger patients that potentially have dry eye. But it is very important to notice that there are sex-related differences in dry eye disease prevalence. And, a large part of it, we think, is the effect of the sex steroids. And for example, the lacrimal gland, it's an androgen target organ. And so, things like low androgen deficiency, it can predispose to lacrimal duct and lacrimal gland dysfunction. And it's also its own separate risk factor for meibomian gland disease. So, in other words, obviously, I have a much lower threshold in female patients, and especially, patients that are pregnant or going through menopause, and ones that are going kind of through all of those hormonal changes, to see the effect of ocular surface disease and dry eye disease, and be a little bit more aggressive in treating these patients. Patients, even women who have Sjogren's disease, also, they notice that they have decreased androgens in those specific patients. So it's just interconnected in multiple, pathophysiology. And it's really helpful to take that into consideration. And then also to think that it's not just, you can have the hypothalamic pituitary hormones and glucocorticoids and insulin, and this concept kind of sex chromosome complement also. So it's definitely something that is really important. Another thing that I think that, DEWS workshop did a really great job of kind of defining gender versus sex. And that really helps with, future studies, because I think in general, in all types of medicine, that's, coming out. And I thought it was really amazing that was discussed in this workshop. And of course, it's important to remember that, gender refers to a person's self-representation. So it can be based on biology initially, and then also the experiences and environment. And then sex distinguishes males and females just based on just biological characteristics. So, I thought that was really great to have that discussion, and, brings up this concept of, care-seeking behaviors and the differences of service utilization in these types of patients. So I really was very pleasantly surprised with that. And that probably has to do with a lot of the new changes.
Chris, do you come across that much in your practice? And I thought that was very interesting from Dr. Sullivan, talking about lifestyle differences when you identify as a different gender. The care-seeking part of it was very interesting. Is that something you come across in your practice?
I mean, in general, yes, but I think that, and in talking to David Sullivan as we did, it becomes very clear that there's a lot more that we don't know than what we do know when it comes to this stuff. And it is very fascinating when you get into the differences between sex and gender, and a lot of the sort of stereotypes that go along with those things, and practitioner stereotypes and patient stereotypes, and in essence, what the DEWS report says at the end is just like, basically, as clinicians, we should take all of this into account, in some way. When you see a patient in front of you, don't make any preconceived judgments based on sex or gender or age, quite frankly, for that matter.
Are any of you in your history asking, aside from male or female, are you asking what you identify as? I know I get questionnaires like that when I fill out things online now. Have any of you changed your history to ask that?
I honestly have not.
Yeah, but you've all come across that, have you not? In filling out, I don't know, I think for my PPP, for my bank loan, I had to say something like that. I get a lot of that in my California questionnaires, but perhaps something worth considering. So Zaina, you can just take us through, and we got these, I want to give credit here. These are quotes from Dr. Sullivan directly, who was kind enough to contribute some real important takeaways from this subcommittee.
Right. And I mean, in general, overall, the main kind of takeaway from this, sex, gender, and hormones does play a major role in the regulation of ocular surface and adnexal tissues. And then that there is a big difference in dry eye disease. Another takeaway is that, the data is not that great in terms of research and, the different sex differences in these things. Even though there's a ton of it, there's a lot of confounding variables, right? Especially age. There's also a lot of differences in pain and the perception of pain that was discussed, which I thought was really interesting in this specific part of the DEWS. So I think this would be an area where I think future research is really needed and important. It's one of those where, yes, we know it, but how can it clinically help us and to continue with that knowledge?
And I totally agree with you. I have some international colleagues that look at me like I have two heads when I tell them, like, oh yeah, we don't have a great way to prescribe, like, for example, testosterone cream. And that's something that's very commonly used outside of the US. And I think that we have a lot to learn in this area in particular, as you pointed out, because it is hard to study. And maybe, if there's better clinical trial design, and as our diagnostics get better, maybe those can be more focal endpoints as opposed to these broader brushstrokes like patient-reported symptoms. Those are very important, but I think that there's so much more that we need in terms of tools in order to be able to assess the impact of some of these treatments.
I believe there was a doctor, and Kelly, maybe you're familiar, at Southern College of Optometry, who was doing testosterone cream.
Yeah, he was. Small studies, so it was really difficult, like N of 30. So it was really difficult to determine whether or not there was utility there. He really felt that there was, although it just didn't get to the point. This was a long time ago. So it really probably, if it had been today, I mean, there probably would have been venture backing to be able to push it a little bit further. But back then, there just wasn't any money to support these sorts of studies. It is really hard to, look at these differences because it's not just the hormone level in the body, for example, because there's the local hormones at the eye and the eye tissues that are likely different from what's happening in the body as a whole. So you can't just, we've done some studies where we've measured the hormone levels, serum hormone levels, and just don't really correlate very well. So there's a lot we really do need to learn. It's a rich area for study.
And we're going to talk a few slides about epidemiology, and as Dr. Starr, you predicted, we're running a little behind, so we're going to move a little quicker. Anyone have any thoughts on epidemiology and prevalence, et cetera?
Well, I can say that from the 2007 to 17, there were a lot more global studies on the prevalence of dry eye, even dry eye and MGD, and how it was classified across the different studies. It's different, but you can put them all together in some diagrams. So the information is in the epidemiology chapters. It was nice to see that there was a growing number of these large studies across the world to show the increased prevalence in dry eye. So
And
I
a
think,
lot of that, it was that's why the definition was so important, right? We talked with Fiona Stapleton. It can vary between 5 and 50%, but a lot of that's just going to be based on how you define dry disease. And the probably the biggest thing, the shift we've seen in the last several years is this increase in device use logarithmically, seemingly, and what impact that may have. So a lot of studies certainly are going to be needed to get a better grip on epidemiology and prevalence, right? And like this mentions here, the economic burden is huge. Absenteeism, presenteeism, where you're at work, but you're not working as efficiently, and that impact on quality of life, which we've all had patients, I'm certain, in our practices who are so devastated. No doubt you've had dry eye patients who are in tears in your chair. Have you all had that?
Oh yeah. I mean, these can be some of our most miserable patients, when they come to you and they've tried almost every single treatment. And these are, professionals who just cannot function, like you said. This concept of reduced work productivity and depression is associated with this. I mean, the impact is huge. That's why it's so important, what kind of the education and the treatments and all of that research.
Which is why early diagnosis and treatment is so important. I had a patient just yesterday drive 3 hours north from Los Angeles to see me because he couldn't get answers anywhere else. And the more doctors we get on board with recognizing early symptoms and the value of early treatment, I think the better. So let's jump.
I would say that our patients are very affected by this and upset, but as far as in tears, I mean, that's the goal, isn't it?
Yeah, right. Right. I would. Yeah, they'd be crying if they could, Chris.
Yeah.
But we don't make fun, so.
Yeah, we're going to see some crossover of these sorts of symptom surveys about presenteeism, absenteeism, and the economic burden. I think we're just starting to see a little bit of that. And it's going to be increasingly important for the pharmaceutical companies and the device companies to be able to argue to insurance plans that their devices and medications will have meaning in that realm, which is a really important realm in terms of productivity and quality of life. So I hope that we'll see a lot more research in that area upcoming.
Yeah, it can certainly be just profound. And I believe the number was about $55 billion burden on the U.S. economy due to absenteeism, presenteeism, cost of care, et cetera. So jumping to our next question, how many layers is a tear film? When you all got your education, how many layers did the tear film have?
Are you asking us?
3 for Priya. Now we're doing sign language.
Oh yeah, there we go. 3. I'm like, wait, this one didn't count, Chris? Wait, that's 4.
I think I
there we go.
Asking my daughter when she was about that age, how old are you? I'm this many. The answer was 3 layers that everyone was taught. Can you let us know what kind of answers we're getting here? So here is a learning opportunity because the correct answer, Chris, is?
The correct answer now is it's 2 layers. According to TFOS DEWS II, it's a 2-layer system. Yeah.
Yeah, Dr. Mark Wilcox, who led the tear film section, brilliant guy, very, very interesting conversations. And who wants to take us through the tear film? Kelly?
I'd be happy to talk a little bit about that. So you may be wondering, well, what happened to what layer is not there anymore? So we still have the lipid layer on the top. We still have the aqueous tear film, but instead of having a distinct mucus layer, it's a mucin aqueous gel. So it's kind of combined where there's different types of mucins that are, some of them are free floating and some of them are bound. But basically the committee felt like since there were free floating mucins in the aqueous layer, you couldn't exactly call it 2 different layers. And so therefore the lipid layer plus the other stuff is now the sort of tear film model that is preferred. And it is a very thin film with a very, very thin lipid layer over top of nanometers, somewhere you see between 50 and 100, depending on what literature you look at. But in general, we're talking about a very complex, thin tear film.
Yeah, the tear film certainly is an interesting thing. When we look for things like MMP9 or osmolarity, I think we don't recognize exactly how many proteins, how complex the tear film is. It's pretty remarkable. And, Chris, we learned a lot from Dr. Wilcox about goblet cells and the mucin layer and the importance of that, which I'm keen on using lissamine green for. And any of you use lissamine green with any regularity?
I think it's, lissamine green is very underutilized as a stain. And, you can just buy those little strips, and there's so many things that you can look at. You can look at the conjunctiva, the cornea, the lid margin. And I feel that way about fluorescein strips also. But I think that, especially as I look and think about, well, what are the less expensive or easier, in big quotes there, but the vital dyes are readily available and do give you a wealth of information.
Well, and it's funny that you say that. So my area where I practice is, I use the same rooms that Steve Flugfelder does. But we're always on different days. So I'm so lucky because obviously he's done such amazing research that I have lissamine green, rose bengal, fluorescein strips and everything. So, and I agree. I actually like looking at the conj, for SLK or things like that with lissamine green. I think it is helpful in the cornea, but I kind of stick to my fluorescein strips. But I do agree it's really helpful with conj and lid margin specifically.
It's really, the lid margin really highlights with lissamine green, and you don't really realize it's there until you actually start making your eyes look at the lid margin. I think there was a lot of lid margin staining I missed in my early career with lissamine green because I just didn't really focus my attention there.
Lid wiper, amongst other things, right? It's really, it's remarkable. Whenever I find a patient with some really, staining I would not have picked up otherwise, that sort of thing, I kick myself for not doing it more often. Or a tear film, which is highly unstable. Maybe it breaks up in 2 or 3 seconds, and there is clearly much value in the tear film. Is such a minor structure of such critical and paramount importance to how we see and how you take your pre-surgical measurements prior to cataract and refractive surgery. Having a tear film in the right quantity and quality is so critical for this tiny little layer. And this I found was pretty interesting. Chris, did you catch this part from Dr. Wilcox? I thought that was really interesting.
About how the lipid layer is not as critical as we thought for preventing evaporation. Is that what you're talking about?
Right. The fact that he said that, it's only reducing evaporation by about 8% or less, yet that makes it very difficult to reconcile some of the studies. So when we do procedures to get the meibum flowing better and we see these increases in tear film breakup time, perhaps there's something else at play.
Yeah, it's probably specific lipids in the tear film and the lipid layer in particular. And I believe that Dr. Wilcox also mentioned the interaction of the lipid and proteins together to make a stable tear film. So it's got to be all of it together. There are over 250 unique lipid species in the lipid layer, and there's well over 500 unique proteins in the tear film, which is just this tiny, like you said, tiny little structure. And so sometimes some of the tests that we do get a bad rap because with all that going on there, you do have to have an adequate amount of tears collected in order to be able to make these measurements. That's probably one of the most critical things in some of the success of future point of care measurements that we'll be taking.
Yeah, and I'd say mucin probably plays a much bigger role than we give it credit for at this point. And that mucoaqueous layer probably has a whole lot to do with evaporation as well.
And Priya, your thoughts on point of care testing, biomarkers, MMP9, osmolarity? We can oftentimes not have a good concept, somebody described the tear film as being composed of 3 layers, and I sort of don't like that, or 2 or 3 layers, but it's not exactly composed of layers. It's composed of a lot of stuff. It may have a couple layers, but the stuff that's in those layers is so beyond what most of us realize. So when we measure MMP9, we're really just measuring one of so many potential biomarkers.
Oh, absolutely. And, at first I didn't like the 2-layer definition, a traditionalist. I like thinking of like, no, but those were the 3, a little rigid to change sometimes. But I actually love it now, because if you, and it ties back to the changes in the definition. The word homeostasis really resonates with me as I think about dry eye and really ocular surface disease, because, it just means something's out of whack. And when I think about the, 2-layer, I think about, it doesn't sit there like a perfect, like 3-layer cake. It's all mixed together, and lots of stuff is happening. And so visually, I think that kind of gets clinicians thinking about this dynamic interaction of things. And then, Scott, you brought up all these, molecular things that are going on. We are just testing, this is like, to me, I say this is like the height and weight when you go to the primary care doctor, right? I mean, okay, it's not super scientific to get your weight and, yeah, they can measure you, but think about, okay, well then your clinician might do blood work, and then you get like all these other pieces of information. We're waiting for our blood work. We are just at the early stages of diagnostics, and don't get me wrong, I think they have pushed us forward in terms of our diagnostic abilities, leaps and bounds. Look, I mean, there was a question in the chat about, okay, well, symptoms and why is there such a disconnect? That's just part of the disease process. And, we're going to talk about pain and sensation in a little bit, but to me, if anybody out there listening from industry, please get us some more diagnostics. We need things that are quantitative, and MMP9 is a great marker. It's a great marker of inflammation. And I use it actually not only to diagnose dry eye disease, but we need quantitative diagnostics. We need an array of tests that profile patients. Part of the chaos of dry eye is that there are different patient profiles. And gosh, wouldn't it be awesome if we could just take a little tear sample? It could take even 10 minutes. I'd be happy to wait 10 minutes for this answer instead of 2 minutes. But, just, hey, this patient has a more inflammatory profile, or a more allergic profile, or a more lipid issue profile. Those are the diagnostics that we need in order to more effectively target and tailor our therapies. And we have great things today, but I would love an infinite number of more things for the future.
And Priya, you mentioned the chat. Are you able to see the questions?
I am.
Good. So before we move on to the next section, let's take a couple questions if you can.
Yeah, I'll knock through some of these. Okay, so someone asked about, I think this is, Kelly, I'm gonna maybe pick on you for this question because it's a tricky one. So, that they said, well, some patients are free of symptoms but have significant signs, and with the most current definition, it requires symptoms, to be part of that. So how do we classify people who don't have symptoms but have signs of dry eye?
So if you go back to that classification scheme, which we just sort of, move through pretty quickly, it starts at the top with symptoms, yes or no. Yeah, there we go. And how fortuitous. And so you see at the top, the patient can have symptoms, yes or no. And if you go on to the left side, the asymptomatic side, that then gets you down into, patients who may be presenting for, say, surgery, and they're not thinking that their eyes feel bad because they're focused on their vision, perhaps. Or you also might have those patients that have really the train wreck corneas, and they just really aren't feeling anything. And so there's asymptomatic, but if you press them, they'll kind of talk about, well, yeah, my eyes do feel bad. And those are the ones that often say, when I got treated, I didn't realize how bad my eyes felt until they started to get better. And so there are ways that you can be dry eye on that side. So you can see that tiny little dotted line that heads to the middle line going down to dry eye. And then on the symptomatic side, the easy ones are just the signs and symptoms. Yes, that's the sort of immediate, straight down the middle, just slightly to the right side under symptomatic, that gets you down into the dry eye disease category quickly. And then there's all the symptomatic side over there where you have the way symptomatic. We're going to talk about pain and sensation here in just a second, where they have so much pain and yet you don't see any signs. Now that can be because it's dry that hasn't happened yet, and that's the second box in. Or if you're on the far right, that's those that have so many symptoms and yet no signs, and we're calling those the sort of neurotrophic dry eye patients. So there's room for all of that. There's room for the patient that doesn't have symptoms, and I'd say press them and see if you can get them to describe symptoms in different times of the year or in different settings or airplanes, and maybe they do have symptoms and they're just not outrightly telling you that. We have a lot of that because we're so quick to go through our exams and we don't always spend as much time really trying to get that information. But the second you see some signs, you can ask them, well, hey, do you have some symptoms, and see what they tell you. And that's a long way to go through this diagram to kind of answer that question. So I certainly think that any of the other panelists might have an opinion too.
Yeah. I think you guys would be crazy to disagree with Kelly, but
I'll tell you the one thing, and Priya, correct me if I'm wrong here. This is a patient who doesn't look great. Their cornea looks terrible, but they're not really complaining.
That's right.
Yeah.
That is a patient that you should grab a 2-cent cotton bud and turn it into a little wisp and touch that cornea and see if you get a reflex, see if they blink, see if they feel it. Because I had never seen a case of neurotrophic keratitis in my practice prior to the introduction of oxybate. And now what I started doing was those patients who we treat them as if they have dry eye disease, we'd go through steps 1, 2, 3, 4, and we can't clear up the cornea. Now I'm starting to test sensitivity, and I have been shocked at how many of them don't blink and don't feel it. So typically diabetics are high on the list, herpes, herpetic keratitis, refractive surgery, cataract surgery, all sorts of conditions that can lead to this. Long-standing inflammation on the surface of the eye in the form of dry eye disease can cause nociceptive damage, which will make you essentially for a numb cornea. And I have been shocked in how much of that I've seen. Have you all found similar?
So it's interesting that you bring this up. Actually, Chris and I did a webinar a few months back, and he actually has a great case. We agree with you. I think the neurotrophic component, first of all, people never tested for it because they never, there wasn't really much treatment right in the past for it. So people didn't really think about it. But now that we're seeing that it's, again, this whole concept of ocular surface disease, and it's not just dry eye. There's a component of, neurotrophic corneas in a lot of our patients that aren't getting better, especially in these advanced patients. These patients end up getting even thin corneas, and you could be treating this dry eye and you're missing completely the neurotrophic aspect. And now we have so many different treatment modalities for it. And yeah, Chris can talk. He has such a great case about that. So I think it's really interesting. But I do think there are patients that are asymptomatic and there's signs of ocular surface disease that aren't necessarily neurotrophic. And honestly, I agree with Kelly. We don't really know, is it just early and they're not, as clear about their symptoms? Is it subjectively, or is there something else at play that we're not yet sure of? So I find that a very interesting aspect, especially some of the studies that show topography and biometry changes, even in patients who are asymptomatic, right? So they do have some form of ocular surface disease.
I'll add to that a very, very important thing in my practice. And I think when I talk to practitioners, when you say they're asymptomatic, and this is what I asked Kelly, I learned from Kelly years ago. I've got these patients, they look terrible. They're not complaining. And your response, Kelly, was you think there's really no such thing as an asymptomatic dry eye patient. I think you're asking the wrong questions. And that's when I threw a validated questionnaire into the mix. And now I have something shown to be associated with disease state. So if I ask you, are your eyes dry? And you say no, that doesn't mean you don't have dry eye. So I can put you through an OSDI or DEQ5. And now I've got these answers and say, oh, you're positive. So when you say they're not complaining or asymptomatic, That was such a valuable lesson for me, Kelly. It changed my entire world, just handing out that questionnaire.
And the other thing is visual symptoms that we don't often
Great.
attribute to ocular surface disease, especially the neurotrophic patients who might not have pain. But if you ask them about fluctuating vision and quality of vision, you're going to find that it's going to be down, and they're going to be symptomatic in that regard if you probe them about it.
And we've got about 2 minutes to answer 20 questions. So Priya, what's the
Well,
next?
you know what? So a lot of these are actually about treatment, so we can save some, you know.
Now let's do that then.
Towards
So
the end.
let's move on to pain and sensation. And, you know, as our disclosures, I do some work for Dompe. I think Chris, you might, and Zaina, you might, and you all might, but it's such a fascinating aspect of what we're doing, being able to work on the neurosensory component of the lacrimal function unit. Really interesting to me. And this is where we spoke to Dr. Carlos Belmonte. What a great guy in Spain. Brilliant guy. We have an upcoming episode with Anat Galor and Pedram Hamra, which I'm very much looking forward to. And I don't know how that's going to be less than like a 4-hour podcast, but we're going to try.
Like a 4-part series.
Chris, you want to take us through this part?
Well, I mean, I don't know how much time we're running. I feel like we just talked about a lot of this, at least in the neurotrophic side of things. And of course, the flip side of neurotrophic is neuropathic. And I think both of those things are very important, and we're learning more about them, and we're going to learn more and more about them. And this chapter in TFOS DEWS II will probably be twice the size of the current one. But I do think in that disconnect between signs and symptoms, that everybody who's on this call and listening to this, that you have to start thinking about those extremes. The extremes on that classification scheme were neurotrophic on one side, neuropathic on the other, and then all the other ocular surface diseases in between. I think it's very important. I think it's important to test it. You mentioned testing corneal sensation. That's important if you're thinking neurotrophic. On the flip side, if you're thinking neuropathic, somebody who has all these symptoms, but their tear film looks great, there's no staining, and you're in the past, our instinct was to say, oh, this patient must be crazy. They can't possibly have all these symptoms. Their surface looks so perfect, but they do have symptoms. They have real pain, and that's neuropathic pain. And a good way to test for that, in addition to some of the classic symptoms of sort of sussing those out, is putting in a drop of proparacaine or tetracaine or some anesthetic, topical anesthetic, and seeing if that pain is still there. If it's still there after a numbing drop, then that's probably a central neuropathic pain.
Yeah, that's great. Do you all do the proparacaine test? Yeah, and it's so much value in that. I mean, if you've got a patient who says 10 out of 10 a pain, and you put in a drop of proparacaine and nothing budges, now that becomes a pain management referral. If they go down to 5 out of 10, perhaps you have mixed peripheral and central. And if it goes away completely, now you're optimistic. You may be able to treat the surface of the eye and get that functioning better. Proparacaine test of really a lot of value in that. So
I think that,
go ahead.
Real quick, I just think that is a really big pearl take home of that particular chapter, is being able to look at it differently. So that what you just said is right on, Scott. I'd encourage everyone to try it if they haven't.
Yeah, it's was eye-opening to me. I just have people where it's sad when you put in proparacaine and there's still, I mean, these people are depressed. They don't sleep well. They react to wind and light. It feels like stabbing in their eyes. And these people can become suicidal, right? These are people who have been to 20 doctors before they end up seeing you. And they really need you to at least acknowledge. I think that part's important. And Dr. Adler and Whitney Hauser talk a lot about that. Just acknowledge your pain is real. I get it. But we need to get you out to pain management to take care of that. And those patients, those are the ones who will cry like, oh my gosh, I can't believe someone's not telling me I'm crazy and offering some help. So moving on to pathophysiology. Who's our pathophysiology expert here? I see you all
Kelly.
raising your
Well,
hand.
not budging. So I will say that this is the biggest chapter of the whole report. And if you're interested in something like you want to know osmolarity, just pull up the PDF and do a word search for osmolarity, and then it'll take you to the part of that chapter and you can do the reading that you need to do, because it is not something that it's like an encyclopedia. You wouldn't really read an encyclopedia, just like you wouldn't necessarily read this particular chapter, but it does highlight so much new knowledge that's been gained, and it has hundreds and hundreds of references. So the chapter is really good in that, but it does, as Maria boiled it down here, kind of show, and this is consistent with the 2007 report too, is that there is this vicious cycle or vicious circle that includes hyperosmolarity of the tear film. It includes inflammatory mediators, changes to the goblet cells in the ocular surface, and tear film instability. And where you enter in that can vary. You can enter in it from all different areas, and you can see there's arrows coming into that main circle in the middle. So you can have instability of the tear film due to a MIBAM issue, evaporative dry eye. You can have Sjogren's syndrome or something leading into the inflammatory pathway section over there. Of course, the resultant of goblet cell damage and epithelial damage is visible, but not always present. And so all of these things are really important, and they all made it into the definition as etiological factors that are important in dry eye. And you see that there's the aqueous deficient on the left and the evaporative on the right, but all of it is in the same cycle. And that's important to remember when you're looking at your patients, that they can have all of these things, but not all of them at the same time. And they can change from one to the other over time. So it's a kind of a complex, confusing diagram. It can be simplified if you just look at that circle in the middle, I think.
Yeah, I challenge you to find an article or publication on dry eye disease that does not have the word multifactorial in the first paragraph, which I think is why so many of our patients have it, right? So many things cause it, so many patients have it, and these are all entry points into this vicious circle.
And I think kind of just looking at it in a different way would help. We talk about how, we want to simplify everything, and that this is complex and there's chaos. But that's also opportunity, right? Opportunity for different objective testing, opportunity for different treatment modalities that can be, additive. So I think just kind of taking a step back and saying, yes, this is confusing, but it's also nice because it gives us more opportunities for helping that specific patient that, you can go through this approach. It helps a little sometimes.
Yeah, I mean, this really is the roadmap to, if you are a drug development company or an instrument development company, where do I want to, find a new test or a new treatment? It's somewhere here. So, and there's that was well worded, lots of opportunity.
Well, Priya, you talk about all the different pro-inflammatory cytokines and other things we can measure listed right here. Interferon gamma would be a great one. Tumor necrosis factor, the interleukins, very important. I know Tear Lab was actually working on trying to create something that could measure more of those. I'm not sure of its current status. And we've got about 20 minutes to get through about 10 slides, so I think we're doing well. Briefly, iatrogenic. Priya, you want to comment on that?
Yeah, you know what? We don't like to blame ourselves, but we cause a lot of dry eye as clinicians. Whether it's the BAK exposure, but also, our colleagues that are not within ophthalmology, a lot of systemic drugs, whether it's, things that diuretics, blood pressure medicines, NSAIDs, the list goes on. And, if you're going to peruse through the report, I actually love to look through all of the figures and the tables, because it's a great way to kind of see what you're interested in. And it's pictorial. It's not reading a lot of text, but there's some great tables on, the classes of medications. And as clinicians, when we go and look at our patients, sometimes just looking at their med list is really important, I think, is the one key takeaway from this section. And while, it might not be realistic that our patients can come off their blood pressure medicines, for example, but I often find there's things that you can point out to the patient so that they can understand, what can be worsening it, but also, causes them to sort of take more responsibility for their disease. So, That's kind of how I look at it. Glaucoma medications, and then of course surgery. You listed a number of surgeries as it relates to neurotrophism, but we still don't totally know why some of these procedures lead in some patients to, significant long-term symptomatic dry eye disease. But when looking at the patients, I think this section just really gives me a lot of pearls and things to say. Okay, I got to keep this in the back of my mind. Their risk factor is not only that they're female and over 50. So
to you surgeons here tonight, LASIK's been around for over 20 years now, and cataract surgery certainly has changed a lot in the last several years. Are the newer techniques more ocular surface friendly, or is it more the recognition of treating the ocular surface disease prior to the procedure, or a combination of both? Because I think we're seeing less complications in terms of dry eye following surgery than we used to.
Yeah. Chris, you want to start?
Well, I think it's a combination of all of the above. I wouldn't say the techniques necessarily are more friendly. In fact, there are some studies that show femtosecond cataract surgery actually induces more dry eye than traditional phaco. We're doing more limbal relaxing incisions, which can certainly affect the corneal nerves, with a femto laser. But I do think it's the recognition. I think that, the whole point of the Ascaris algorithm, which, by the way, Scott, you mentioned earlier, you gave me a lot of credit for, but Priya was just as instrumental in that whole thing as I was. But that was why we took that on. It was very important to Ascaris as an organization to identify these issues around surgery and refractive surgery and the visual implications, certainly, of ocular surface disease, and how can we better diagnose it prior to surgery and deal with it prior to surgery so as to avoid any potential complications afterwards. And so we spent a lot of time working on that. And of course, that whole initiative would not have been possible without the TFOS DEWS II report first, because we based a lot of our algorithm and a lot of our thought process and the schema on the DEWS II methodology. But I do think that we're better at identifying this because of all of things like what we're doing tonight, the Ascaris algorithm, and so many other educational initiatives that we're recognizing it. We have great treatments, we have great diagnostics, we have greater understanding around this disconnect between signs and symptoms, and so we're identifying it, and we're all learning that we need to address this, and I think patients ultimately benefit the most from that.
Has that changed your communication with patients ahead of time in terms of expectations and post-operative management?
Yeah, 100%. Yeah.
No, and I was just going to add, in terms of, cataract surgery, I echo what Priya and Chris have already said, but, patient expectations are much higher now for cataract surgery, for example. They're not just wanting to take out that cataract and then wear a pair of glasses and kind of, move on. It's more like, you want to take out the lens. They want to see distance, intermediate, near, perfectly without, requiring many things. And I think, we're learning more and more the importance of ocular surface disease to get to these outcomes that patients are expecting. And I think with that came the early diagnosis and all of these educational, aspects, and that people are just much more aware of it. And I think that's how it's coming up. And so sometimes patients are sent to us for cataract surgery, and it's really ocular surface disease that's the issue. And it's not that they need cataract surgery. So on one level, it's good about talking to patients and patient expectations, but sometimes they don't like what you have to say, but it's really important to say it anyway, because operating would be so much worse in those cases.
And speaking of Iatrogenic, Chris, give us, I know you're heavily involved in the new workshop. Give us a 30-second overview of the new workshop from TFOS.
Well, yeah, the new TFOS, I think it's called a lifestyle epidemic, is going to kind of delve into those aspects of how lifestyle affects ocular surface and dry eye disease, and similarly how dry eye disease affects our lifestyles, quality of life issues and things like that. And it's going to touch upon a whole bunch of things, but one of the big ones is, the sort of post-COVID era that we live in. And actually, this is one of the questions that one of the audience members asked about digital screen device and sort of the increased screen time in the post-COVID era, what is that doing to our eyes? And I think that those effects are pretty significant. And that's one of the key questions that the next workshop is going to look into.
Yeah, no question. I'm having teenagers and younger kids have their parents bring them in because their eyes are bothering them from the increased virtual schooling that they're getting. And this is the first really 10-year-old kids saying, hey, mom, I need to go get my eyes are really bugging me. You know, we used to think it was the video game stuff, but now that the screen time, one study was just quoted that the average screen time to some particular group was 16 hours per day, essentially every waking minute, which is pretty sad, not just on the eyes, but the rest of the body. That can't be good. So we look forward to that new workshop. And our last question, and this is a really an interesting one. And Priya, you played a role in this diagnostic aspect of the algorithm. Which of these elements are key? The top ones are all of the following except which one? And go ahead and answer that. Or no, we're asking which are key elements. Are we asking, what is the question we're asking here?
Which one of those is not? Which one is not an element of the TFOS algorithm?
We're missing the word except in there, I think.
Yeah, I was like, wait, I would pick more than one.
Yeah, right. Right.
Okay, so if you wanted to pick more than one, you guys out there, you won.
Yeah. So Priya, go ahead and share the answer with us, with the group.
I mean, I would say all of them.
But there were keys.
No, which one is not part of the TFOS? There's one of those that's not part of the TFOS algorithm.
Not right. The first, not the
screening algorithm.
Right. So tear breakup time is
in.
Oh, MMP9. Oh
it was MMP9, so
like,
we'll not make it into the top.
Guys, I'm sitting in the West Coast and living in East Coast time. So it's like in my brain.
Right. So questionnaires, critical, vital dyes, like you mentioned, Priya, is so important. Tear film breakup time has a lot of value. And osmolarity has always been a part of the TFOS trial workshops, but MMP9, it was a secondary measure, I believe, along with meibography. So Priya, I hate to do this to you, but give us about a minute on the diagnostic methodology.
Okay. Well, you know what was amazing is that in a room sat 8 or 9 clinicians that came from all over the world. So imagine taking the practice patterns and tools that might be available, you know, in the US, and then applying that to people from various countries in Africa, you know, small remote clinics to, you know, just all over the place. And so trying to meld all of, hey, what do people have access to? What do we need? And so we wanted to use, you know, identify tests to diagnose and monitor the disease, figure out which tests had the most evidence. That's, you know, ultimately TFOS DEWS II is an evidence-based approach. And then number 3 actually was important, and we spent a lot of time thinking about the order as well as the technique. And as you see, once we go through the slide, you know, there's so many tests that are out there. So by no means, just because we picked the ones that we did, you know, those are the most studied, the most validated. It doesn't mean that the other tests are invalid or not helpful. And so, you know, basically, again, as we talked about earlier, we suggest that you use a questionnaire to identify symptoms. The 2 questionnaires that were chosen, so you pick one, either the DEQ5 or the OSDI, and that's because they had a lot of evidence and well studied in literature. And then you had the signs, which was you could do ideally non-invasive tear breakup time. So, you know, like the keratograph type device. And if you didn't have that, you could do fluorescein, and then osmolarity, or using fluorescein and or lissamine green to look at the surface staining of the conjunctiva, eyelid margin, and the cornea.
Yeah, and also I'll be stronger than that too. Use a validated questionnaire. That's, I think, just so important.
Well, I loved your comments about you're not asking the right question. You know, what Kelly told you, because that's just a great way to say it. You know, our dry eye patients don't speak in one language, and they don't say, oh, I have pain, you know, or, oh, my eyes are dry. I mean, they say all sorts of other descriptors. And sometimes, you know, it's even a quality of life change that we then correlate to dry eye, you know, like driving and being comfortable, you know, with certain visual tasks. So I agree completely.
It's also the consistency of a questionnaire that doesn't depend on my mood or what I feel like asking, or did I remember to ask all the right questions. I like the consistency, especially for following treatment plan along the way. Are we making, I mean, we care about symptoms, right? That's a big deal. So I want to be able to demonstrate your OSDI was 30, now we've got it down to 8, and so showing that progress, I think, is really important.
Metrics, absolutely.
And also, it's one thing we just didn't talk about really quick is, you know, it'd be nice to do 1,001 tests on every single patient, right, to help us and ask 1,001 questions. But there's also the aspect of efficiency and being able to see these patients and getting quicker for the diagnosis. And so I think this was great, you know, Priya, in terms of picking which testing and would help to do those to reach that. And also, obviously, the questionnaires is vital in doing that, because we don't have the time to ask all those questions individually to every single patient.
Yeah, your staff can hand that out at reception. And just a quick run through here, we talked to Lyndon Jones about this, the original dry workshop matched severity with treatment, and this is more a stepwise approach, but there are caveats to that. This can all be found, by the way, at tearfilm.org. You can download the entire workshop in several different languages, but here's steps 1, 2, 3, 4, and we'll just kind of highlight a couple.
Real quick.
Yeah, Kelly.
If you go back real quick, because it's important to the one diagram, that one more. So what Priya was talking about is in the blue box in the middle here, and it has the cut point. So do encourage you to go to the tearfilm.org website, to the diagnostic chapter, and then you can see what values you need to have to get in, and it's symptoms and one of those 3. And it tells you what cut points for each of those that you need. And it's super simple. So you can do it with, if you don't have osmolarity, you can use your slit lamp and some dye and do a tear film breakup time. It's super simple. You know, keep it simple. And so I just wanted to kind of point that out. If you're wondering, well, what can I do to start? That's your very best place to start. Sorry, Scott, for hijacking, but it's a really important point.
You are not hijacking, Kelly. I'm just trying to make sure we get done on time. That's all. No hijacking here at all. Appreciate you being here again. So there's the steps 1, 2, 3, 4. Briefly, Chris, you want to take us through step 1?
Well, yeah, according to the steps in TFOS DEWS II, is you let's say you have a dry eye patient, first time visit, they're a virgin, they've never been treated, you know, for dry eye or diagnosed. So you want to start step 1, you know, which is education and environmental concerns, maybe nutritional concerns, and sort of educating the patient on these sort of quote unquote simple things, you know, lubricants of various types, depending on if it's more evaporative or aqueous deficient. You might choose a lubricant based on one of those things. Lid hygiene and warm compresses, and those are important, and that's a good foundation for the higher steps.
Great. And Kelly, how about step 2 for you?
Step 2 is when step 1 is kind of failed, and so you're adding on a variety of different treatments, and this is the kind of the bucket, you know, everything is thrown in here, and you're probably wondering, which do I try first? There's not a lot of evidence, and that's why this is so vague in a way, because there's not a lot of comparative evidence of one treatment versus the other. So they're all just sort of listed, and they range anywhere from tear conservation with punctal occlusion to all the anti-inflammatory medications that are prescriptions that we have available to us now. And so it really just puts them all in a list. But at step 2, you should be doing something more than just palliative. And I think that's important to note. And step 2 is a bit of a broad range as well. So, you know, you can start easy, and then you can even add on one on top of one another, or one treatment on top of one another if you'd like in this. And I think this is one of the areas where we've seen even a lot of change and new information over the last few years since it's been published. And we will continue to see information here to give practitioners guidance as to which to start with. And everyone's got their own opinion. And so I'm sure some of my colleagues here can maybe voice theirs, because there's some questions in the chat about it too.
Yeah, and I personally think 1 and 2 is going to handle a lion's share. That darn punctual occlusion, can't quite get past that constant punctual occlusion. Zaina, how about step 3 from you?
Yeah, so some of the, I mean, I think to kind of bring step 2 into 3 is, it's not one or the other and then I stop step 2 all the medications and then jump to step 3. So of course it's all continuum. There's a lot of new medications that are a lot of new drops that we're able to utilize, different formulations of cyclosporin, topical LFA, and topical steroids, and all of these new Demodex drops. So but some of these patients, like I have graft versus host disease patients, or some of these really advanced patients that are just not getting better on some of these medications, serum tears has been just such a game changer for so many of our patients, especially in the graft versus host disease patient spectrum. But even some of these neuropathic pain patients, I put on serum tears and you can see improvement. So that's one thing I utilize significantly in my clinical practice. And then scleral lenses has been phenomenal. Again, we're in Houston, and Fluke Flood are set up our PROS clinic, but not just the PROS device, but also all these different scleral lenses and eye print lenses, and of course you guys, the optometrists, have to credit that how much of that work has gone into improving patient lives, because it not only helps with the ocular surface disease and dry eye, but it gives you your optimal vision too in some of these patients that have irregular astigmatism. So you're really hitting and treating 2 things at the same time. So I feel like those 2 things have been game changers.
And if you don't fit sclerals, find someone who does, because it really
Right.
can be the last resort, but it can be a lifesaver. And Priya, you want to talk about the punctual occlusion again?
On time for occluding.
Don't be late, doctor.
I always start with the semi-permanent punctal plugs, and only if the patients are really have demonstrated that they don't have worsening of symptoms, and it really is, hey, they fall out every 3 months and I don't want to come see you every 3 months, then I'll consider cautery. But I think punctal occlusion is actually used a little bit too early for a lot of docs, and they don't treat the inflammation on the surface or allergic disease. And sometimes the plugs get a bad rap of, oh, I got so much worse. But increasing the tear volume of a healthy, or of just a reduced volume tear film, that's a great treatment option. And then, the other approaches on here, tarsorrhaphy, salivary gland transplantation, I mean, that is like, put that in the obscure bucket.
Yeah.
I think, when I'm doing tarsorrhaphy and things like that, those are patients that have neurotrophic cornea, terrible exposure, breakdown, impending perforations, etc. So that's much different.
That really goes beyond what's typical dry eye. And just a couple quotes here, which I'm just going to leave up here because I believe this is our last slide. And Dr. Jones talked a little bit about, don't necessarily, if you've got a patient who's severe, you may want to take step 1, but also add step 2 into the mix. So sort of, this is a framework again. And Priya, we can maybe take 1-2 questions and then we're out of time. Anything that you'd like to share with us? And we'll give one person the chance to answer it.
Yeah, some of the questions here are actually related to, excessive screen time in our younger populations. And how are we taking that treatment algorithm and applying it to this younger population? Any changes or anything different that we're doing?
I had a 9-year-old come in, a precocious 9-year-old doing 14 hours of screen time a day, very high speed score, but she was savvy enough to understand, what, you've got a problem here and you've really got to make some big changes. I saw her a month later. We reduced her screen time down to 3 hours. We did artificial tears. We did an oral nutraceutical. I gave her some GLA and she really got so much better. A lot of it just comes down to take that phone away. There was a study done by Moon in South Korea several years ago that showed these symptomatic patients 7 to 12 years old, signs and symptoms of dry eye, took their phones away, signs and symptoms went to 0. So that's about education and lifestyle modification. That's not somebody that's going to be on Restasis, for example, right?
Yeah.
Well, next step would be a salivary gland transplantation, of course.
That's the chaos. Chris.
Tarsorphy.
That's the chaos. You got one more question and for somebody else here?
Yeah. So just our next question, there's a lot of questions actually related around IPL as it relates to treating MGD and dry eye or chalasia. Are any of you using IPL?
I use IPL.
I do too. So
I mean, ocular rosacea, right? I think that's a key target for me. What about you?
Yeah, absolutely. Can't treat higher than skin type 4 patients. So any of my patients that have a lot of inflammation, patients that have severe meibomian gland atrophy, I actually steer them more towards IPL because, it's a repeated treatment. But I do think there's something to be said for reduction of that telangiectasia that for a lot of these patients are more of the inflamed phenotype. I think they do great with IPL.
Do you add in meibomian gland expression later?
I always do it. So I do the double pass, the TFOS method, and then the expression right after.
But are you doing something like a tear care or something, an iLux later, or LipiFlow later?
Not as a standard. I would go through the series and I see how they do. Often, if they're on the more severe side, the IPL kind of jump starts things. But certainly in those moderate to severe patients that are still symptomatic, I would absolutely, lean towards an iLux or LipiFlow or tear care.
Yeah, Dr. Toyos really came up with some great data, that serendipitous discovery. And our colleague, Dr. Laura Perriman, got the Perriman protocol. She's done a lot of work and on chalazion as well. So there's a lot of great research. And I just want to thank you all again. I'll be respectful. I think we are out of time. We're 4 minutes over. Apologies for not getting to all of your questions. The key thing I'd like you to know is you can go to tearfilm.org and download this entire workshop. How do you read 400 pages? Well, one bite at a time, right? So you can download them by subcommittee. Very, very interesting. Anything else anybody else would like to add here?
Well, and I think there's an executive summary too that's helpful for people, who aren't going to, read the 400 pages. So that's also pretty detailed in terms of kind of the big takeaway points. So that's one other thing. And you find it in the same place. It just says executive summary.
Great. Thank you all again. I sincerely appreciate it. I love working with all of you on this. It's been a blast. Time flew by. There's some information. You'll get an email on how to get your CE credit. And thanks again for watching tonight, everybody.
And thanks, Scott,
thanks for moderating.
For guiding all of us.
Thank you.
And you too, Chris.
Thanks.
Yeah. Great to see you, Priya and Chris.